Hey everyone, this is a brief talk on hip labral tears. I prepared this presentation as part of my family medicine clerkship during my third year of medical school, and we will walk through the basics of hip labral tears and the diagnosis and treatment and management of these conditions. Okay, so to start with the basic science, the hip labrum is a horseshoe-shaped ring of cartilage lining the acetabulum within the pelvis. As you can see, I'm kind of shaping it out here with the laser pointer. I finally figured out how to do that. So the function of it is to cushion the hip joint and retain the synovial fluid that helps with lubrication and weight distribution. It contributes to hip stability through a suction effect, and it has an articular and a capsular surface. That the capsular surface can't really be shown here because the capsule has been cut to see into the joint. So the cartilage, it's made of fiber cartilage. It's abundant in type 1 collagen and contains less proteoglycan than hyaline cartilage. This resists high degrees of tension and compression, and it is commonly found in tendons, ligaments, intervertebral disc, articular surfaces, bones, menisci. And fibrocartilage does not have a perichondrium, so it does not heal very well. So let's keep going here. So this is the link of the basic science to the disease. The tear of the acetabular labrum results in the compromise of joint stability, loss of the seal, and disrupted joint lubrication and weight distribution. So you can imagine this would be very painful or disruptive to somebody playing sports or even just walking around, moving. Tears can be seen in people of all age groups, but most commonly occurs in female athletes, is what the literature says about that. And there are multiple different mechanisms of injury. You can have femoroacetabular impingement, a traumatic injury, or degenerative change. So femoroacetabular impingement is usually based on the shape of the femoral head and neck, and then the acetabular, the cup shape. Trauma, something that happens to it in an acute moment, and then degeneration is a chronic change over time. So there are a couple symptoms and physical exam maneuvers we can do to kind of figure out if someone has a hip labral tear. So symptoms, they'll have mechanical hip pain, and they'll have a snapping sensation. That would be the labrum flipping around inside the joint. They can present with a vague groin pain. A lot of times they point to the inside of the thigh, and that's kind of like where bony hip pain or pain inside the hip joint usually refers to. If they point to the outside of their hip, that's usually not something inside the joint. That's usually something like a muscular or pain over the greater trochanter area. And then it can be locking too, right? So if the labrum is torn and it flips into the joint and catches, it can feel like it locks up because it gets in there and just prevents movement. So you can differentiate the where the tear is in the anterior and posterior parts of the labrum based on doing how your physical exam. So if they have an anterior tear in the labrum, they'll have pain when the hip, you start it in a flexed, externally rotated the hip, and abducted. So Faber, right? And then and you extend the hip, rotate the hip internally, and then adduct it. Okay, and then if that elicits pain, kind of moving the leg in that direction, that can give you a hint that it's an anterior labral tear. Whereas it's for a posterior tear, if you have the hip flexed, adducted, and internally rotated to where you extend, externally rotate, and abduct, that gives you a hint that it is possibly a posterior tear. So this guy here, he's got the hip flexed, externally rotated, and looks like a little bit of abduction, right? So this right here is the starting position for a anterior tear, and then he's going to extend the hip, internally rotate, and adduct it, bring it towards the midline. And if that brings pain to this guy, then that is a hint that he's got an anterior tear. So to evaluate and manage these evaluate and manage these injuries, or degenerative changes, or FAI, injury to the labrum. You want to start with an X-ray plain radiograph. This can help you exclude all other causes of hip pathology like dysplasia, arthritis, or acetabular cysts. If those are negative or inconclusive and they're still having pain, you can move on to an MRI arthrogram, which is the gold standard of diagnosis and has a 92% sensitivity for finding a labral tear. So that means if you have 100 people that definitely have a hip labral tear, and you put them through a MRI scanner, 92% of them are going to be picked up by the MRI. So, and that's just based on numbers and measurements. Or, how am I trying to say this? This is just based on observations in clinical practice and research. So to treat, a lot of times operating on the hip is, not what patients want, and a lot of times not what they need. So you always usually want to try a non-operative course first, and that comprises of resting, giving them NSAIDs, physical therapy, or even steroid injections into the joint, just to kind of calm it down, reduce the inflammation. A lot of times, if the labrum is not flipping back on itself, so as you can see here, there's a little hyperintensity right here, and if it were to flip back, that could cause more of a functional problem as well as pain, and then lead to quicker degenerative change, an earlier onset of arthritis. So that would usually be a case where you would want to operate. And so you can do it arthroscopically. You just go in with an arthroscope and you just debride the flap, the part of the labrum that is flipping out. If the labrum is in an area like on the periphery of the labrum where there is a better blood supply, like kind of they say the red zone, it's analogous to the meniscus. The red zone that has better blood supply, you can suture that back down, okay, and repair it rather than just trimming out. It's kind of like the analogy I've heard is a hangnail, right? So it's just dead skin hanging off of your finger, and you can suture that back down to the finger, but it's not going to it's not going to regrow. It's just not, you just have to cut it off. That's this scenario with the debridement. If there's a area, and they call it the white zone of the cartilage, of the fibrocartilage, and it is just hanging in there, you usually just have to trim it out. And then if it gets so bad that it they have other arthritis, they have other issues in the joint, you could, in a worst case scenario, consider a hip replacement. Now, I will say, if they need a hip replacement, the hip labral tear is probably not going to be their presenting issue. It's probably going to be osteoarthritis or a traumatic fracture necessitating a hip replacement. So let's look at the actual process. So here we go, the labral repair. Okay, so they have a tear there on the periphery of the labrum, close to the area where the blood supply is, and you can just suture that back down, and a lot of times it'll take. Okay, so it's indicated in patients who have symptoms that have failed to prove non-operative treatment. You always want to try to do non-operative management first, and then, or for full thickness tears at the labral chondral junction, so where the labrum meets the articular cartilage. And I looked at a couple different articles on this, and at the time of my making this, which was in the fall of 2022, okay, so science advances very rapidly, but at the time that I made this in the fall of 2022, there was not any conclusive data on follow-up. So guarantee you soon there's going to be a meta-analysis coming out on the outcomes of hip arthroscopic labral repair. Here is the scenario I was talking about earlier, kind of like the hangnail coming off of the labrum. This is like where it's just flapping and, it's not vascularized. It's not going to regrow if you suture it down. So, and it's getting in the way, it's flipping into the joint, and it's just causing problems. So the only thing you can do is trim it out. Um, and it's not near the labral junction where the blood supply is better, right? So you do this in people who have symptoms that fail to prove non-operative treatment. They've tried a non-operative trial. They've done, what you've said, and it's still not getting better. Or you do this for a labral tear that isn't favorable to repair, like I just described. So how you do it is you just remove unstable portions of the labrum and any inflamed synovium that's around, and then you address the hip pathology that could have caused the labral tear, such as the femoral acetabular impingement. That's a whole nother talk, but that's kind of like, there's like cam type and pincer type, and then there's mixed. It is super superficial. Pincer type is where the acetabular cup is too overreaching, and it comes over the femoral head too much. And whereas cam type is where the femoral head is irregularly shaped. It kind of comes out. It's like very convex on one side, and it can grind into the acetabulum, and that could tear the labrum. So that is, something that is another hip pathology that could have happened, and then you can correct that as well operatively. And then post-operative care, generally you want to limit weight bearing for at least 4 weeks and limit the flexion and abduction for about 4 to 6 weeks is what I read. And then outcomes of this debridement, 70 to 85% of patients that undergo arthroscopic labral debridement experience short-term relief of symptoms following arthroscopic debridement. And long-term follow-up data are not yet available. It is generally patients do well with this. And those are my references. So thank you all for watching.